I want to thank everyone for joining us today for our last session of the day. This is where we're going to present the 2023 Jenny Pomeroy Award for Excellence in Vision and Public Health. I'm Jim McGrann, and I have the honor and privilege to be the current chairman of the board of the Prevent Blindness organization, and I'm going to be your moderator today for the session. The Jenny Pomeroy Award for Excellence in Vision and Public Health is named for Mrs. Jenny Pomeroy, who served as CEO of Prevent Blindness Georgia from 1996 until 2013, and was a champion for the role of public health in vision and eye care services and programs. The annual award recognizes an individual, team, or organization that has made significant contributions to the advancements of public health related to vision and eye health. The awardee was selected by a volunteer review committee, including ophthalmologists, optometrists, and researchers who all have a public health focus. Dr. Dean VanNasdale, an associate professor at The Ohio State University College of Optometry, was selected for this year's Jenny Pomeroy Award for Excellence in Vision and Public Health for his significant contributions to vision and public health research. He has collaborated with the Centers for Disease Control and Prevention's Vision Health Initiative to develop state profiles related to vision health, and is conducting pioneering work in Ohio, using multiple surveys and administrative sources to estimate the impact of state policies on improving access to eye care. The goal is for this work to serve as a template for similar analysis in other states. More recently, he collaborated with the Vision Serve Alliance to develop a series of innovative state-level profiles regarding vision and health status among older people. In addition to teaching at the OSU College of Optometry, he serves as a mentor to master's and PhD students working in population health. Dr. VanNasdale currently serves on the advisory committee for the Center of Vision and Population Health at Prevent Blindness, and is a member of the Vision and Eye Health Surveillance System expert panel for NORC at the University of Chicago and the Centers for Disease Control and Prevention. Please welcome Dr. Dean VanNasdale to accept the 2023 Jenny Pomeroy Award and provide our closing presentation. As a reminder, you can submit your questions anytime during the presentation through the Q&A button at the bottom of your screen. Dr. VanNasdale, thanks for being with us, and congratulations on the Jenny Pomeroy Award.
Thank you very much for the very kind introduction. I've got my award right here. It's truly an honor to be the recipient of this award. I'd like to thank Prevent Blindness and the award committee for this honor and the opportunity to talk to everyone today. When I think about the past recipients of this award and the ongoing legacy of Jenny Pomeroy, I can't fully express my appreciation for this recognition. Thank you very much. And I want to talk a little bit today, use this opportunity to discuss how in Ohio we've been using population health data to try to promote eye health and try to better understand the impact of some of the policies that have been put into place to try to improve access, and to see whether or not those things are actually making a difference, but also trying to quantify the magnitude of some of the upstream determinants and the downstream consequences of blindness and low vision. One of the things that I want to emphasize, though, is that while I'm the recipient of this award, really it's an enormous team effort. So none of this is actually possible without the people who I work with every day. That includes people at Ohio State University. One of the people who I think is really going to be, I think, a pioneer in this field in the future is Dr. Erica Shelton, who's an optometrist, now working on her PhD. She's working a lot on pediatric vision care access, and I would keep an eye out for some of the work that she's going to be doing in the future, because I think it's really going to be groundbreaking. But I also have people like Lisa Jones-Jordan, who is an epidemiologist who works here in the College of Optometry, and Matt Robish, who is a biostatistician. Both of those help us extract the data and make sense of it from a lot of different surveys and other health surveillance instruments. Prevent Blindness Ohio, we work with pretty carefully, and we've worked with for a really long time. Sherry Williams, who is the retired CEO of Prevent Blindness Ohio, has really been influential in a lot of the work that we've been doing too, and David Mondor has really helped out quite a bit. We have unique collaborations with the Ohio Department of Aging, Mark Millay, who's retired. I did my PhD and postdoc work at Indiana University and still work with one of my collaborators there, Chris Clark. But none of this is really possible either without the funding that comes from the National Association of Chronic Disease Directors. Carol McPhillips Tangham is one of the people who's really helped guide the direction of some of our work over the past several years. And also Dr. Janan Sedin, the team lead at the CDC Vision Health Initiative, who's really been instrumental in sort of getting us to think about how the work we're doing can be applied and trying to make it more translational in nature. So this is my outline for the talk that I'm going to give today. I'm going to give you guys a little bit of information on the background on how this became important to me and what kind of mentorship I had to get us to where we're at now. And then I want to talk a little bit about where we find some of the data that we use, try to give you a little bit of an idea of what the data are telling us or what we think the data are telling us, and how we use those data to try to identify upstream influences that we think are impacting both the prevalence of blindness and low vision, but also some of the associated health outcomes, and then talk a little bit about some of the future work that we're planning on doing, some of the data that we already have also. So starting off with a background, this is a picture of really the person I consider to be my public health mentor, John Cruz. And several years ago, I first met Dr. Cruz at the American Public Health Association Vision Care Section meeting, and he was transitioning to the chair of that group and had mentioned that if anybody needed anything, to let him know. As the chair, he'd try to do whatever he could. He was a senior scientist at the CDC at the time, has since retired, but continues to work with us. And he's really the person who guides a lot of the work and gives us a lot of the ideas that we use to try to sort of advance vision health in Ohio. So really, I think people could consider this almost, Dr. Cruz has won the Jenny Pomeroy Award in the past. I almost consider this as his second Jenny Pomeroy Award, because all of the work we're doing is heavily influenced by the things that he's sort of taught us and the guidance that he's given us. I want to talk a little bit about some of my first clinical experiences as it relates to public health and some of the things that stuck with me, and why I think both vision health and incorporating vision health into interdisciplinary models of care turns out to be really important. This is on the left, a picture of Dr. Mark Swan. I did my optometry school work at Michigan College of Optometry at Ferris State University. And during my fourth year externship, Dr. Swan had just started a clinic in Grand Rapids, Michigan, and he had put together a vision care clinic that was part of a multidisciplinary care center that was providing care to people who might not otherwise have access to it, not just vision care, but also primary care. And so we were seeing in that clinic a lot of patients who had diabetes, who had not ever had eye exams before. And one of the patients that stuck with me was a patient that wasn't much older than I was at the time. So keeping in mind, this was a while ago, I was sort of in my mid to late 20s. This patient who was about my age showed up in the clinic, who was diabetic, had never had an eye exam before, but had some of these changes that you can see in this picture on the right-hand side of the slide. This is from a video from the National Eye Institute. So for people who are interested in seeing what kind of things we see clinically in the eyes as it relates to diabetic eye disease, the National Eye Institute has some really phenomenal videos, and this is just a link to that video. But what you see here are small blood vessels in the retina, or the neural tissue that lines the inside of the eye, and those blood vessels in diabetes leak. I had heard part of the presentation by Dr. Bressler earlier talking about some of the things that they see clinically and things that really concern them. And in the patient that I had seen at the time, I saw a lot of these sort of pathological changes that were indicative of diabetes in somebody who had never had an eye exam before. The reason that that's concerning was because this is a relatively young person. The longer people are diabetic, the more likely they are to develop vision loss from diabetes. And diabetes is the #1 cause of vision loss in the working age population in the US. So this was really one of my first experiences clinically related to public health, and started to guide my thinking about how vision should be sort of incorporated into more holistic models of care. And if you look at some of the national health objectives we have, I heard earlier people citing Healthy People 2030. So these are the 10-year national objectives for improving health for all Americans. And these are sort of evidence-based or science-based or epidemiology-based. So there's data sources that we use to look at baseline for these objectives, and then look 10 years later to see whether or not we're meeting those objectives. So if you look at some of the things that come out of the vision work group objectives, you've got one objective that is to reduce vision loss from diabetic retinopathy in adults age 18 years and over with diabetes. And just to be more specific, this is vision objective 4. And if you look at what their baseline numbers are, they're looking at 33 per 1,000 people. And what their target is over a 10-year period is to get that down to 16.5 per 1,000 people with diabetes who are experiencing vision loss. And so this is a pretty ambitious goal if you think about it in the context of the direction that we're heading or the trajectory that we have sort of working against us. Because if you look at data that come out of the National Eye Institute, projections for vision loss over the future are not working in our favor. So if you look at in this graph here from the National Eye Institute, you've got vision impairment projections looking at 2010 to 2030 to 2050, broken down by different race and ethnic groups here. And what you notice is that across the board, the projections for vision impairment in the future are all going up, and going up at a pretty significant rate too. So if our goal is to try to reduce vision loss from things like diabetic eye disease in the future, we already have some significant obstacles that we're working against, and projections that vision loss is likely going to get worse for the foreseeable future. So if you look at the more information that comes out of the National Eye Institute, they recognize that this is a growing issue. Diabetic retinopathy, like I mentioned before, is the leading cause of blindness in working age adults, those 20 to 74 years of age. And if you look a few years ago, you've got 7.7 million people. 2030, that's anticipated to be about 11 million people, and then 2050, 14.5 million people. So our goals to reduce vision loss due to diabetic retinopathy are going to be even more ambitious if you look at it in the context of where we're heading. And one of the things that should be encouraging, though, is that the vast majority of vision loss due to diabetic eye disease can be avoided if you've got early detection, timely treatment, and appropriate follow-up. So you're looking at the potential to reduce risk of vision loss in the diabetic population by 95%. So our goal to reduce vision loss through the guidelines and sort of objectives in the Healthy People 2030 initiative isn't unrealistic if we look at it as far as the amount of vision loss that we could potentially reduce through more sort of early interventions. In 2016, there was a report that came out from the National Academies of Sciences, Engineering, and Medicine. And this is really the most comprehensive, really compilation of information in public health and vision that has ever been put together. And so anybody who wants to know anything about sort of either where the data sources are that collect vision health information and how that sort of relates to either comorbidities or other health outcomes, this is the go-to place. And one of the quotes that stood out to me in this report was that sound decisions about policy and the prioritization of resources depends on having relevant and timely surveillance data. Surveillance of vision impairment and eye health is limited, however, and the lack of adequate surveillance has a substantial impact on public health efforts to address vision problems. So one of the things that they're highlighting is that we need timely surveillance data to assess where we're at. Those surveillance data should be able to help point to what some of the risk factors are that might be avoidable. And then we can also quantify the magnitude of blindness and low vision by looking at other health outcomes. And so we're still sort of in an early state here. So if you look at the picture on the right here, I've got this road that's sort of traveling off into the distance, and you've got mountains in the background, and we're sort of at this starting point here on this road, and really want to get to the top of these mountains, but the path to get there isn't really clear. So we've got to look at some of these data sources and try to make sense of complex associations to try to identify upstream influences to vision impairment to try to mitigate some of the downstream consequences that we see. So I think it's important when we're trying to figure out a path of how to get to where we want to be as far as reducing unnecessary vision loss is to look at the data and understand what the data are and how we can use those data to better plot our course forward. And this is the public health framework that I use a lot, and it helps guide my thinking. So this is sort of a circular diagram here, and on the outside you've got these categories. So in the circular diagram, it's sort of iterative, so it goes around and around. And when you look at the outside circle from about 12 o'clock to 3 o'clock, you've got assessment. From about 3 o'clock to about 7 o'clock, you've got policy development. And from about 7 o'clock back to 12 o'clock, you have assurance. And this, once you go through this cycle once, you sort of assess where you're at, and then you go through the cycle again. And then inside, you've got these 10 essential public health services, which are sort of wedges in sort of this circular diagram in sort of like a pie shape. So you've got monitoring health from about noon to 1, diagnosing and investigating from about 1 to 2, informing, educating, and empowering from 3 to 4, mobilizing community partnerships from about 4 to 5, developing policies around 6 o'clock in this diagram, enforcing laws from about 6 to 7 o'clock in this diagram, linking into to and providing care services from about 7 to about 9 o'clock, assuring competent workforce from 9 o'clock to 10 o'clock, and then evaluating all of those things from about 10 o'clock to 12 o'clock. So this is the framework that helps us think about the direction that we need to go to when we're looking at data. And so we're going to start off with monitoring health. All of it at the center is grounded in research. So this is a picture of my PhD advisor. So my PhD work was actually in retinal imaging and data modeling, not public health. And Dr. Ann Elsner was really focused on trying to make sure that there was better access to care in the population. So even though I was doing things that were people might not intuitively think of as public health oriented, my PhD advisor always framed things in a public health context. And when I was working on my PhD, we were looking for early biomarkers for ocular and systemic disease. The eye is sort of the window to a bunch of other systems in the body. And what we were doing was trying to see whether or not we could find aging changes and then use those changes to see whether or not we could find other neurodegenerative disease that was sort of consistent with more systemic problems, things like diabetes. And so one of the things that she told me when I was working on my PhD is that we had to consider the tools that we had at our disposal and decide which of them we could use to most effectively solve our problem. So in the imaging world, you have a whole bunch of different tools that you can use to identify different structures in the eye, but understanding the mechanism of the disease helps you understand which tool you should be using to try to find the pathological changes that are associated with that disease. But really, that advice is generalizable to almost anything, including public health. So when we're thinking about using health surveillance tools and data to try to plot our path forward, coming up with the best resources to give us the most insightful information turns out to be really important. And so when we're looking at monitoring health in this public health framework, these are some of the sources that we think are most important, or the sources that we've used historically to try to give us the most information. We use things like the American Community Survey, which is administered by the US Census. And these go out to people nationally every year. People think of the census as collecting data only every 10 years. The American Community Survey is actually part of the census, and it's collecting information on an ongoing basis. And people respond to those surveys by mail, in-person interviews, internet or telephone. We also use the behavioral risk factor surveillance system, and that's administered by the U.S. Centers for Disease Control and Prevention. And this is a telephone survey. This telephone survey surveys a little over 400,000 to 450,000 people per year. And the one good thing about these two surveys is that they have a question that assesses vision impairment, and that question is, are you blind or do you have serious difficulty seeing even when you're wearing your glasses? So we've got a common tool across these two different surveillance mechanisms that can give us sort of complementary insight into what some of the upstream factors and downstream consequences are of vision impairment. And if you think about it, you're collecting data through the US Census. Those data aren't going to be the same types of data that you're going to collect when you're looking at health surveillance data that's going to be collected by the CDC. But things from the American Community Survey can give you information about sort of some of the social determinants of health, economic stability, and things like that. So when you use these two in combination, you can actually learn quite a bit more information than you can learn about blindness and low vision through either one of them individually. And this question has been used for quite a while and is considered a valid case definition for epidemiology research. So we've been using these two data sources quite a bit over the past several years. And to help understand how we use some of these data, I think it's important to understand what the components of the BRFSS looks like. And what you've got is a core module. These are questions that are asked to everybody without any modification. And then you've got optional modules. So you can have a standardized set of questions that's developed by the CDC, and individual states can either elect to include those questions or not. One of the nice things about the optional modules is that several years ago, there was a vision module that had a number of vision-specific questions that was incorporated into the BRFSS, and the state of Ohio incorporated that module every year that it was available. So we have really good baseline data. And then you can ask state-added questions. So if you have a specific topic of interest, you can go through a competitive process to get questions added in your own state related to something that might be of interest that's sort of a unique issue. So we've been able to get individual questions related to vision added in the state of Ohio that we can use to track changes over time. And this comes from a presentation that I gave several years ago as part of a trip that I took with the National Alliance for Eye and Vision Research in Washington, D.C. So what they did was they were looking at, making the case for increased funding for vision research. And originally what I had planned on doing was talking about this stuff that I had done during my PhD work and postdoc work that was funded by the National Eye Institute. Some of the stuff that we were doing was in Steve Burns's lab, who does high resolution imaging, and we were looking at early changes in diabetic eye disease. So I put that as part of my presentation, but at the time we had started doing more public health research too. So I sort of split my presentation and included stuff related to the public health work we were doing. We were starting to look at some epidemiology data in a couple of different states, starting off with Ohio, Alabama, and Nebraska. And what I found was interesting was when I was giving this presentation, my colleagues who are also doing vision research were very interested in the right side of my presentation here, where I've got pictures of the retina capillaries, visual function stuff, which we still do in the lab that I have here at Ohio State. But when we took this information to policy people, so legislators and their aides, what we found was that they weren't as interested in the clinical translational science aspects of it. They were more interested in the epidemiology aspects of it. So that sort of led me to think that what we need to do if we want people to emphasize vision health is find a way to engage people who are working at the policy level. And so this sort of directed us on a path to start looking at data in a way that we could assess policies and engage policymakers. So we go from data that we use to monitoring health now in this public health framework to diagnosing and investigating problems. And so I'm going to talk a little bit about what we're learning from some of the data that we find. And one of the nice things about health surveillance mechanisms like the behavioral risk factor surveillance system is it doesn't just collect vision specific information. It also collects information on other comorbidities. And if you look at data in the US, you've got a significant number of people, 4 in 10, who have 2 or more chronic conditions. So what we can do is with the behavioral risk factor surveillance system in the core module, they ask a question now thinking about your physical health, which includes physical illness and injury for how many days during the past 30 was your physical health not good? And so we can start to look at this question in combination with our vision impairment question, and it gives us some pretty good insight. So you've got a depiction of normal vision here from the National Eye Institute, and what we found is in the non-visually impaired population, the number of physically unhealthy days out of 30 ranged from just under 3 to just under 5. So between 3 and 5 physically unhealthy days in the non-visually impaired population nationally versus in the visually impaired population, what we found was a range between a little over 8 to a little over 13 physically unhealthy days. So you can start to see differences or disparities in people who are reporting vision impairment versus people who are not reporting vision impairment. So now that we can sort of quantify this, the next logical questions to ask are what are some of the conditions that are contributing to the poor physical health in the visually impaired population? And then what's the overall magnitude of those problems? So it's sort of this sort of stepwise approach. We get a broad picture and then we sort of narrow it down a little bit. And so when you look at things like diabetes and blindness and vision impairment, these two conditions aren't mutually exclusive. So how do we look at these things in combination? And we can do that pretty easily using national health surveillance data. So what we started doing was looking at diabetes. And we looked at the prevalence of diabetes in people who were self-reporting vision impairment. What we found was in the population that was reporting vision impairment, 17% of those also reported being diabetic. And then we can make comparisons with people who don't report vision impairment. And what you find is much less. Only 8% of those who were not reporting vision impairment reported also having diabetes. And then we can look at other things in the behavioral risk factor surveillance system like mobility issues. So we can look at difficulty walking or climbing stairs. And when you look in the visually impaired population, those who report vision impairment, 37% of those report mobility issues versus only 11% in the population that's not reporting vision impairment. So you see really big disparities here. And these combinations matter because when you're thinking about really significant health outcomes, things like falls are really important. And this comes out of a paper that the CDC Vision Health Initiative put out several years ago. John Cruz was the lead author on that. And what they found was 52% of individuals 65 years and older with severe vision impairment reported having a fall in the previous year. So these are things that sort of resonate with policymakers in ways where you can sort of make an impact. And when you look at behavioral risk factor surveillance system data, you can get state level estimates of vision impairment. But I live in Ohio, and anybody who knows anything about Ohio knows that there's a lot of health disparities. And so when you start to try to figure out how do you come up with more granular data or how do you more carefully identify locations of greatest need, you can use things like the American Community Survey, which now gives you county level data showing that in the south and southeast part of Ohio, vision impairment is much higher than it is in other places in the state. And anybody who knows about Ohio, that's intuitively obvious probably. But for policymakers to be able to quantify that, it turns out to be really important. So we decided what we needed to do next was use these data in combination from the American Community Survey and the behavioral risk factor surveillance system to try to figure out ways to inform and educate and empower people. So what we did was we put these data together. They were adapted by the CDC's Vision Health Initiative, and now these are state profiles on vision health that you can find on the CDC Vision Health Initiative's website. And so for each of the states, we've got data about comorbidities and other upstream health influences that we think are contributing to poor vision health in each of the different states with county level maps of where vision impairment is worse within a state. So this is Steve Burns. He is my postdoc advisor. He's married to Dr. Ann Elsner, my PhD advisor. Their labs are right across the street. He does very phenomenal high resolution imaging. And I remember once I brought him this really interesting picture of the retina, and he said, "That's an interesting picture, and I have to figure out what it means and whether you can do anything about it." So that's sort of where we're at now, trying to identify what the upstream influences are that are leading to the poor health outcomes that we see, and try to understand ways in which we can address some of the upstream influences for vision impairment, so we can mitigate the prevalence and avoid a bunch of unnecessary health outcomes through earlier prevention. So if you look at things that come out of the National Academies of Science, Engineering, and Medicine report, what they did was they took this primary prevention, secondary prevention, and tertiary prevention, which are sort of common terms used in public health. But what they also did was they expanded this model. So this circular framework I'd been talking about, they took the circle and expanded it into a cylinder. And this circle actually works at each different individual level of prevention, including what they deemed important influences, and they called them primordial prevention, or ways to improve health by targeting behaviors and social and physical environment. So the more upstream we can move, the better we can address health issues where we don't end up having to preserve vision if we can avoid vision loss to begin with. And a lot of this stuff is related to social determinants of health. So we can address things like education, access and quality, healthcare access and quality, neighborhood and built environment, socialism, community context, and economic stability. We can start to make a difference in some of the outcomes we see related to vision health. And one of the things we focused on is healthcare access and quality in the state of Ohio. So what we did was we looked at data that's Ohio specific. In one of the surveys, it says during the past 12 months, was there a time when you needed vision care or eyeglasses but could not get it at that time? So we looked at the vision impairment prevalence that we get from the American Community Survey. We can combine that with data that we get from the Ohio Medicaid Assessment Survey, which samples everybody, not just Medicaid. And we can see locations where there's high vision impairment prevalence. You also get high levels of unmet needs. So now we can direct policymakers to try to address vision loss in places where you've got high vision impairment prevalence rates, where people say they can't access care. And so we use that to evaluate some of the policies in the state of Ohio. Ohio is a Medicaid expansion state. With Medicaid expansion, more people have access to vision benefits, presumably. So what we wanted to do was we wanted to test that. So what we did was we added questions that were included in the vision module several years ago, reintroduced those questions as state added questions in sort of a unique way to test change over time. And what we found was that the primary reason that people didn't seek vision care services is that they were asymptomatic and didn't perceive a need. Even though insurance coverage for vision care services increased between 2005 and 2011, and then 2018, 2019, utilization of services remained relatively stagnant. And so going from informing, educating, and empowering to mobilizing community partnerships, more recently, we've been doing work with Vision Serve Alliance, who does a lot of work promoting vision rehabilitation services, to try to figure out how do we better address some of the other Healthy People 2030 objectives, increasing the use of vision rehab services by people with vision loss. If you look at this baseline numbers, 4.3%, our improvement over 10 years, I would say, is not overly ambitious, the 6.2%. And then increasing the use of assistive and adaptive devices by people with vision loss, 12.4% to 15.9%. So what we're doing is putting together data to write reports that we can use to try to get policymakers to better understand the implications of vision loss, specifically in an aging population. And then our future work is looking at things like mentally unhealthy days, similar to what we saw with the physically unhealthy days, but now thinking about mental health, which includes stress, depression, and problems with emotions. How many days during the past 30 was your mental health not good? And so now we can make those same comparisons. And what we see is that people who report vision impairment report significantly higher days of mentally unhealthy days. If you look at people who don't report vision impairment, you've got a range between 2 to 11 mentally unhealthy days out of 30, versus people who do report vision impairment, that goes up to a range between 4 and almost 16 mentally unhealthy days out of the last 30. And so what we're doing is now starting to use things like artificial intelligence and machine learning to try to model some of these complex interactions that we might not be able to determine on our own. This is work I'm doing with Chris Clark at Indiana University, and hopefully what that's going to lead to is identification of better ways where we can try to prevent vision loss earlier, and ways where we can improve quality of life by making sure people are able to access vision rehabilitation services. But there's still a lot of work to do. So this is really the take-home message, is that the reason for collecting, analyzing, and disseminating information on a disease is to control the disease. Collection and analysis should not be allowed to consume resources if action doesn't follow. And this is a quote from William Faggy, who was the former CDC director. So if you think of this public health model, I've talked a little bit about monitoring health, diagnosing and investigating, and trying to inform, educate, and empower. But really, my skill set only covers a relatively small part of this pie. So really mobilizing community partnerships and developing policies is stuff that I'm hoping that other people, many of the people who attend this summit, which is what makes this summit such an amazing thing, to try to continue to move the ball forward and develop policies that are going to help us achieve those Healthy People 2030 goals. And these are some of the resources and useful links that I think are worth knowing about for anybody who's interested in some of the stuff I've talked about in this presentation. And I'd like to thank you very much for the opportunity to speak in this award. It is really a phenomenal honor.
Dean, thank you so much. That was such an awesome presentation, and you know, for everyone, that connection between eye health and overall health and wellness is just so critical. So, you know, thank you again for that, and congratulations again on the award. As I mentioned before Dean started, please submit any questions you have in the Q&A by hitting the Q&A button at the bottom of the screen, and we'll respond to as many of the questions as we can. There was a question that came in to the regular chat while you were speaking, Dean, and it was, is there a way to prevent the blood vessels in diabetics from leaking?
The best way to prevent that is to try to control blood sugar as much as possible. And I think that really goes towards the coordination of care. That you've got sort of indications in the eye of systemic disease, making sure that people who are evaluating people's eyes for diabetic eye changes are coordinating care with primary care providers or endocrinologists. Turns out probably the most effective approach. That's why I think these data turn out to be so important, is because now you can make that case and quantify it.
So how do you, as you look at all this work, and you touched on a little bit, but how do you anticipate population health data being used in the future?
I think that there's a lot of different data sources that are sort of emerging. I think some of the stuff that we're going to be looking at in the future is going to be electronic health records data. So you're going to have data from a bunch of different providers looking at a bunch of different things, and you're going to be able to see better associations. And so you're going to be able to use those data to see, you know, what's happening in the eye, and then what kind of other markers are you seeing in different parts of the body for systemic disease, to try to come up with ways where you can monitor some of those things a little bit more effectively in the eye, and then give us a better understanding of, you know, the things that we see in the eye. What are the mechanisms for those things that we see, things that we don't yet fully understand? People are starting to look at things like changes, cognitive decline, and things like that, where we see associations with vision loss in cognitive decline, but we don't fully understand what the mechanisms are. How do we better identify changes in the eye that give us some indication, or maybe even predictive or diagnostic capabilities for people who are at highest risk? So I think that's good. Future.
Great. What do you see as some of the biggest obstacles to collecting vision health data, you know, on a population scale?
I think it's difficult because a lot of the data that we have are self-report, and so there's inherent limitations in that. We don't really always know what the underlying cause is of the vision impairment, but it's, I think, the best that we've got, and we can use that data to understand a lot of associations. So it's imperfect, but one of the biggest obstacles. I think another thing that is another obstacle is trying to, when you're collecting data from different sources, even though you're using relatively similar mechanisms, those data aren't always comparable. So trying to come up with ways where you can make those data, harmonize those data, and sort of integrate all of it together, I think turns out to be really important, but it's a big obstacle. And the people who are working at at Newark with the CDC Vision Health Initiative are doing really a phenomenal job trying to integrate all of that stuff and come up with numbers that are consistent and make sense.
That's great. So what I'd like to do is, one, again, thank you so much for the presentation and congratulate you again for winning this award. It's much, much deserved based on what we just heard. But I'd like to remind everyone that's listening, as we wrap up the session, Dr. VanNasdale will have a video chat available for about 30 minutes. The link's available in the chat in the auditorium session description. I'm gonna hand it over now to Jeff Todd to just provide some closing remarks.
Thanks, Jim, and thanks so much, Dean. I consider Jenny Pomeroy not only a colleague, but a good friend, and I know she'd be very happy with the selection. The work that you do is very much right up her alley. Congratulations.
Thank you.
So in addition to that, I'd like to thank all of our presenters and moderators for their time today, and thank all of you for joining us on this first day of our 2-day summit.